Okay, good evening, everyone. Hope your weekend is going wonderful. My name is Dr. Mahader, and I'm a junior doctor of dental medicine graduate from Addis Ababa University. Today's webinar topic is fundamentals of clear aligner therapy for general dentists, and our presenter is Assistant Prof. Dr. Dida Boru Liben. I would like to inform you that this session is being recorded, and our session will be taking 2 hours approximately. In the last 30 minutes, we will be responding to any questions that you may have. Until then, you may keep your questions in the Q&A box, and I will be forwarding them to our presenter. So before we begin, a little bit background about our guest speaker tonight, Assistant Professor Dr. Dida Boru Liben. He is a highly skilled and self-motivated doctor of dental medicine from Jimma University, Faculty of Medicine, and has also a special certificate in orthodontics, again from Jimma University. Dr. Dida is also a certified Invisalign provider with 8 years of clinical experience and dentistry. And Dr. Dida is a devoted academician, orthodontist, and clinician who has been handling complex clinical cases, both at his own practice and multiple private practices in Addis Ababa, including Smile Special Dental Center. Dr. Dida has also done multiple researches. Some include prevalences of periodontal disease in pregnant women, hospital antenatal care, smile characteristics of individuals with different age groups. So very excellent reputation. And on the behalf of our attendees in Ethiopian Dental Professional Associations, welcome Dr. Dida. So without further ado, I'll leave the stage for you, Doctor. You can go ahead.
Okay, thank you for presenting, and I think I really appreciate the EDPA for organizing this excellent webinar. These are very good for the CDP, Continuous Professional Development. I thank all the involved stakeholders in organizing such a wonderful session, and really happy to join you all. Can you hear my voice, please? Confirm me, let me continue if you hear my voice. If you
Yes,
can't
doctor.
hear me, please let me know.
Yes, doctor, we can hear you. You can continue.
And you can hear me, yes?
Yes, we can.
Okay. Let us continue today's topic. Yeah, let us continue today about today's topic, which is fundamentals of clear aligner therapy for general dentists. Let me, yes. These are our contents of today. First, we have to go through the introduction. What are the clear aligners? Among the clear aligners, the Invisalign is chosen as a pioneer to be presented about Invisalign. How does it work? It's biomechanics and aligner fabrication, as well as the limitation of Invisalign or clear aligner. What case we can treat with and what case we cannot treat with. As introduction, as you know, majority of adult patients seek orthodontic therapy this time. Why? Maybe due to the financial independence or due to personal influence. Also, the adult population do not like the metallic appearance of fixed orthodontic treatment. Some of them are had this due to the pure aesthetics, or they may reluctant to use due to fear of pain as well. So for this kind of population that are massively being involved in the clear aligner therapy or being pushed toward the ortho treatment, what are the choice? We can say the clear aligner choice give us an excellent choice for adult population. As Brice and Nielberg says, physically attractive people achieve higher level of life. That's are maybe their personal opinion. So this personal and professional influence may lead the mass number of adult population in seeking treatment for orthodontic treatment. So for that orthodontic treatment, they may choose clear aligner therapy. So what are the clear aligner therapy first? They are custom-made orthodontic appearance that work progressively by aligning the tooth using series of removable trays. There's are also called invisible braces, and they are modern orthodontic solution designed to straighten the tooth. They are more comfortable, removable, and making them attractive choice for adult population. What are the top 10 clear alignment companies that we know? There are a lot of clear alignment companies, but these are top 10, like Aligner Technology, Clear Correct, 3M, Diamond Clear, Sure Smile, Spark Aligner, Clear Smile, OrthoSnap, and Clear Correct. These are top 10 clear alignment companies, but I choose from them Aligner Technology, which we are being practicing in Addis Ababa currently. It's called Invisalign System. So how the Invisalign system come to life? They are developed by two MBA students from Stanford University in 1997. How does it happen is that the ZHist, the adult orthodontic patient, were treated with fixed orthodontic appearance before, and then at the finishing, as his treatment is being finished, he used the removable retainer, the retainer that, visible retainer or vacuum formed retainer. And then when he left the retainer at home, about 2-3 days, his tooth go back to the normal position. Then when he wear it back, his tooth is corrected. So click his mind that maybe we can use a clear aligner to treat the malocclusion rather than fixed orthodontic appearance. So they use the CAD-CAM technology to mass produce aligner that is capable of treating broader range of malocclusion. They are being assisted with Robert Boyd, the orthodontist of that time, by being consultant. So aligner technology received FDA clearance in 1998 and began commercializing it in 1999. Even though the clear aligner technology is cutting edge, the idea of aligning the tooth with plastic aligners or series of aligners was not new. Dr. Kessling started this concept in 1945, but he realized that the laboratory feasible, as there is individual cases for every aligners. So he couldn't make his dream into the reality. So what happened is that the Kessling forecast that one day in the future, maybe the technology will come and make his dream the truth. So with advent of computer age, the aligner technology come and make the Dr. Kessling dream come true. Why now? Why the clear alignment therapy at this time? Because the awareness of the patient increases, awareness for the aesthetics, and also awareness that the fixed orthodontic appearance may trap a lot of plaques which are disastrous for periodontal health of the patient. And many patients may don't want fixed orthodontic appearance, especially adult patients and retreatment or relapse cases. Appreciation for the benefits of technology as well. Especially teenagers and young adults believe that the technology can enhance or boost the treatment results. So, and this is the factor that may push the people, including teenagers, toward the clear aligner therapy. How does it work? The clear aligner therapy actually works by continuous and small forces, not that much heavy forces, but continuous and persistent forces that make the movement of the tooth simpler. Let us see the overview. Aligners, clear aligners work is first, the previous impression. The time, this time there is a scanner, but previous or polyvalent synoxial impression are taken with a wax bite of the patient, radiographs and photographs, and then this impression will be scanned with a CT scan, which is made of impression and the virtual model for the patient. And then using the free software, they used to simulate the teeth movement is that the doctor prescribed for them to move. The doctor actually fill on the prescription of the patient what he need, his treatment plan, what he has in mind to achieve to be corrected the malocclusion of the patient. The doctor will fill it in the prescription form, and then uh, using treat software that aligner technology technicians will move the according to the plan of the doctor. So they will send what we call clean check back to the doctor. Either orthodontics or general dentist, they will send back to the doctor, and then the doctor will check on the clean check software. I will show you what is clean check on the next slide. Then on the clean check, currently the doctor have IDS, especially on Invisalign. IDS is Invisalign doctor site. They will check on that if their plan is correctly, properly addressed with the aligner technology technician. If they have a doubt, or if not, some issues are not addressed, the doctor will send back the correction to the aligner technology. But currently on the advanced software, you can edit with the 3D, the position of the tooth to wherever you want, and you can live update it. After live update it, you can see, you can send back to them to be as approval. Then stereolithographic models. Once the virtual models are made, then stereolithograph will make a physical model. This is aligner technology work. They make a physical model. When the physical model is made, the aligner will be fabricated. Nowadays, we have a digital scanning technology. Instant, no need of impression. Instant virtual model will be made from the intraoral scanner. These are the scanner, for example, it's called iTero, which is unique for the Invisalign, this iTero, and it can be scanned. This is our team scanning with iTero of the patient. Once it is scanned, it will be sent to the aligner company on the IDS. It will be directly available there. Let us see overview of clear alignment therapy. When we think of treating the cases with clear aligner, what we have to do is first we have to select the case. What type of case we are going to treat with aligner alone, or what kind of case we can treat with aligner in combined with the auxiliaries. The auxiliaries can be a TAD, the auxiliaries can be elastics, auxiliaries even can be the expander itself. And once we select the case, there should be a case recordings of the patient, high quality impression or intraoral scan, 3D virtual setup, and treatment progress stages will be made with aligner technology. Then for approval, they will send for you on the IDS, Invisalign doctor sites. Then once you approve it, construction of aligner will go on. So, and then issuance of aligner, you will monitor the patient after that. Once you get your aligner, you will monitor the patient, do the finishing, the retention will continue. So let's go to the diagnosis and treatment planning. What are the selection criteria? Fully erupted permanent tooth is preferable, even though there is the Invisalign package that is called the Invisalign Fastest for the pedi patients. Is here, the tooth should be fully erupted as a permanent tooth. Otherwise, the aligner will not retain on the short crown, and the aligner will not go ahead with future and predicted growth. Then growth has minimal effect on the treatment. So you have to rule out there will be a growth in the future. Mild spacing to moderate spacing up to 6 mm, crowding as well up to 6 mm. Narrow arches that are dental in origin, which is purely dental, 4 to 6 mm. This does not rule out the usage of the Invisalign in case of severe treatment. This is the case with Invisalign alone. You can combine it with another auxiliaries and use Invisalign as well. What are the tooth movement is possible? Space closure is possible with Invisalign. Movement of the tooth after IPR if there is a crowding, or if you want to correct mesiodistal relationship or sagittal relationship, you can also use IPR, not only for crowding. Dental expansion is also possible, about 6 millimeter to the side. Special expansion is feasible in the premolar side, as you know, commanded. Extrusion and intrusion is also possible. Distalization possible with Invisalign, especially 2 to 2.5 mm until 3 mm. Currently, it is possible to distalize with Invisalign. Flaring is also possible to be moved. What are the difficult scenarios that can be treated with? It is difficult. Difficult does not mean it can't be treated, but the difficult case, severe crowding that is more than 5 mm or more than 6 mm, also then skeletal discrepancies, anterior posterior discrepancies. With Invisalign alone, anterior-posterior skeletal discrepancies may not bring you a good result if you did not combine it with another auxiliaries. Difficult to truth extrusion. Extrusion with Invisalign is possible until 0.87 according to some literatures till 1 mm as well. If you assist with auxiliaries, you can even achieve beyond 1 mm as well. Severely TP tooth, especially canine and premolars, more than 45 degrees, need auxiliaries. Here, crossbite is as well. Since the thickness of the aligner will disocclude the jaws, the crossbite correction, mainly dental crossbite. Skeletal crossbite is even difficult to treat with fixed orthodontic treatment. So minor crossbite, especially of dental origin, can be corrected with Invisalign. Surgical orthodontic treatment. There is an orthodontic procedure that is called pre-surgical orthodontic procedure. Mainly, this procedure is a discompensation. As we know, the skeletal orthodontic problem have compensation mechanism for the skeletal discrepancies. So we can use Invisalign as a decompensation mechanics. Decompensation mechanics is for the Invisalign as well. Then clear aligner therapy may be a good choice for a patient with mild anterior open bite. It is good if the anterior open bite is not more than 4 millimeter, because with open bite closure, we have to have the room for the overcorrection as well. If the open bite is more than 4 millimeter, it may not be good to treat with aligner alone. It can be treated with aligner plus the auxiliaries like that. Invisalign indicated for mild to moderate crowding and spacing till to the up to 6 millimeter. Submitting the cases. Once we diagnose, select our cases, the next step is submission of the cases. With complete an Invisalign system, once completing diagnosis and treatment planning, we can submit it. Submit copies of all diagnostic records and treatment plan for the reviews. Uh, there are 4 required records for Invisalign treatment. Impression. Nowadays, there is also we can use impression as well. It can't be ruled out as well. Bite registration, photographs, X-rays, and prescription form. Actually, prescription form you can find on IDS, Invisalign doctor site. Scanning and digitization. Once you do scanning, you can submit your case. What type of impression we need? Impression should be taken with PVS, polyvinyl siloxane impression. Both upper and lower impression should be taken even if we are treating one actually. It is recommended to clearly capture the distance of the second molar, otherwise the retention of appearance will be in question. High quality impression with PVS. The most common shortcoming is failure of sufficient details distal to the second molar. If we didn't take that, the Invisalign retention will be in question and it won't be accepted as well from the aligner technologies. Surface or immediate air bubbles also not acceptable even in normal impression that we are taking high quality impressions with PVS are look like this one. This one is bite registration. Bite registration can be taken. I will show you on the next slide. This is called one-step impression taking techniques. First, you have to put the heavy body on the frame. Then you pour the light body on it and then take impression with this. It's called one-step taking impression for the Invisalign. At registration, you directly inject the light body on the occlusion of the patient from the second molar to the second molar of the other side, and then you will tell the patient to gently bite on it. First, you have to tell the patient to practice by opening and closing. Once you are confident that, you will pour it over the occlusion of the patient and tell the patient to gently bite on it. Then you register the bite directly without wax. Then the photographs, radiographs of the patient, and you will fill the prescription form. Photographs is necessary for all the patient. You have to know the bone level of the patient. If the patient is periodontally compromised, you have to rule out every disease, even for Invisalign, before treating the cases. The photographs should be here. Profile photo, frontal view, and smile view, intraoral, upper occlusal, lower occlusal, upper right, lower right as well, and frontal view of intraoral photographs. Once you take the photographs, what is the aligning technology procedures? Once you take PVS, your impression, in case you use impression, you will have to send to the aligner technologies. Once aligner technology receive your impression, they will scan it with the CT scan. Then they will make a virtual model from your impression. After that, they will cut into a lot of slides and make the digital image called xenograms. Slice reconstruction from these xenograms will turn it into the virtual models. So these virtual models will be electronically packed, inverted, and will be converted to the physical models with stereolithographic. Before turning into physical models, once they prepare the virtual model, they will set the tooth into the position according to the treatment plan. After that, they will send back as a clean check to the doctors. Then the doctor will check his clean check. After clean check, after checking the clean check, if the treatment is as the doctor predicted, he will approve it. If there is any correction, the doctor should send back it to the aligner technicians, or he will edit, especially with the current software, you can edit on your IDS using the 3D editing techniques and live update immediately on the CleanCheck software and send it back as approval to an aligner technology. Bear in mind that CleanCheck is virtual setup for you. It is not the treatment plan by itself. It is a tool that can use as a diagnosis and treatment planning, a tool that can use as a communication to the patient, a tool that can use as a referral to another doctor. It's not a treatment plan. The technology will help you make it easier for you to treat the patient, but all the diagnosis and treatment planning is on your shoulder. As we know, garbage in, garbage out. If your treatment plan is wrong, you cannot blame the aligner technology for not being achieving your treatment goals. This is how the clean check looks. This is actually the older clean check. The current clean check has even 3D editing. You can play from here around here, then it will show you how the malocclusion is being corrected, the number of the aligners, they will show you here on the clean check. Once you approve, you will send back to aligner technology the approval, and then the aligner technology work follows. Stereolithography is a method of converting these virtual models into physical models for each and every stage of the movement. If the aligner is 20, the 20 physical models is needed for those aligners. Every aligner have their own models. The movement per stage is about 0.25 mm per aligner and per tooth as well. What are type of Invisalign treatment? If it is up to 7, we can call it express, light, full, or comprehensive. Currently, they can categorize as light, moderate, and comprehensive as well. Let's go to the biomechanics, how the aligner move the tooth. Actually, as we know, in fixed orthodontic therapy, the biomechanics is very important things. We know how this device is moving the tooth, the way of moving tooth. Some have that it means the physical means and bio means. With aligner, the plastics actually encapsulated the tooth. So it should provide attention, and also it should provide the active force to move the tooth. The retention is actually provided with the undercuts of the natural undercuts of the tooth, but the active component that moves the tooth is with the deformation of aligner. Aligner is elastic, it can deform in different direction, and so that it can move the tooth as well. The retention can also come from attachment itself. It can come from the undercut of the tooth. So what factor important is that aligner deformation cannot be enough to overcome the retention forces as well. And there are certain direction also that aligner can move the tooth more than the other. Aligners is very good in pushing force, but poor in pulling the tooth. So considering all these factors, the aligner will move the tooth to some extent. So that is why we need the different many numbers of aligners to achieve our treatment goals. How this biomechanics works. Let's discuss about the attachment, because this biomechanics can be achieved through the attachments. Attachments are small pieces of light-cooled resin composites bonded temporarily on the tooth. Initially, technicians designed the virtual resins in the virtual model. Then they will make the aligner attachment template from the first model, the original model of the patient. Why attachment? Why we need attachment? It helps in the tooth movement and aligner retention as well. In traditional orthodontic appearance, we know that we have a brackets and wires. The wires will transmit the force, and the bracket will apply this force to the tooth. How the aligner technology achieving the tooth is that there is analogy to this scenario. Aligner can act as a wire, and attachment can act as a bracket itself to transmit the force to the tooth. Attachments can be conventional and optimized. Conventionals are of standardized shape and standardized size. It's standard by itself, it is not optimized. Optimized means that it is customized to the patient's crown size and shape. It depends on the shape. Some crown size is wider or longer or shorter. So the optimized attachment, especially smart force features, are unique to even Invisalign than others. Smart force features are engineered to deliver force system depending on the crown shape mesiodistal width as well, and length of the crown. And position also can be included in this design feature. Attachment categories. There are three fundamental categories of attachment: that assist in tooth movement, and that augment appearance retention, because retention we can achieve with the undercuts of the tooth, those that provide the auxiliary function, and those the purpose of this aligners attachment is in retaining the aligners as well as providing the surface of which the aligner acts, and that will help us in achieving the biomechanics that we need. According to new attachment protocol, the attachment can be passive or active. Passive attachment is for retention and for anchorage. Anchorage means that we are using another tooth to apply the force on the other tooth to achieve what we need as a movement. Active attachment are used for rotation of the rounded tooth, extrusion, intrusion, and even mesiodistal tipping of the tooth. Aligner technology actually have three types of attachment here: ellipsoid, rectangular, and beveled. Beveled is actually modified attachment is for intrusion, extrusion, as well as for ease of removing and inserting the aligner itself. Ellipsoid attachments are often placed horizontally, default for the extrusion and intrusion of the incisors as well. There's 1 millimeter in thickness and placed between cervical and middle third of the tooth. The vertical attachments are used for the root tipping, mesiodistal movement of the tooth. As we know, when we apply chain on the round wire in fixed orthodontic therapy, the tooth will tip. The tooth will tilt into the extraction space. That means it will make a tipping movement and there will not be a root movement. In this case, the vertical attachment also help us in moving the tooth and moving the root into the extraction space. And this paired attachment also act as a two-point contact. As in case of brackets and wires, as we know, we have two-point contact for generation of moment when we move mesiodistally tooth into extraction space. Vertical attachment for divert rotation of canines and premolars as well, and they can act as controlling of the root, especially when we're moving to the extraction space. Here, rectangular attachment, when we apply it, it can all apply for you intrusion forces, extrusion forces, mesiodistal forces, and then the moment can be generated when you move the tooth mesiodistally. Here, the aligner, not as in bracket and wires, it will wrap around the tooth. It will give us advantage of applying the force on wide surface area that will distribute force up until the center of resistance as well. Here is a picture that shows the horizontal, vertical, horizontal rectangular attachment. Horizontal rectangular attachment can be beveled gingivally for extrusion or beveled incisally for intrusion of the tooth. It will augment the intrusion by itself. The aligner can make intrusion, but when you add attachment, it will augment the intrusion as well. Controlling of torque as well. Here, the aligner basically apply about 40 gram of force, 40 gram of force. When it is applied, let's say this is called the lever of arm. When the force is applied on the 10 millimeter lever arm, about 400 milligram of force is generated. This much force will make a body movement. If the force is less than 280, it will move the controlled tipping, lingual tipping of the tooth. It will not make body movement. Another alternative to the rectangular attachment is corrugation. that is called the power edge. This power edge is actually designed with aligner technology next to the gingiva to augment the torquing movement in case of the cases that need torquing lingually or dactyly. Rotation can be achieved with aligners, but severe rotation more than 45 degrees is difficult to achieve with aligner alone. It is recommended to use extra attachment lingually, or it's recommended to use auxiliaries. Lingual buttons can be used as in these cases in combination with aligners. But beware that when we use a lingual button while moving the tooth, we have to avoid unnecessary movement by adding attachment to the tooth, especially vertical attachments to the tooth that we are using as anchorage. Anterior extrusion. Aligners are good in making intrusion, but we need the anchorage. The anchorage can be added on the posterior sides, as you see on these pictures. The anchorage, how we going to achieve the anchorage is that one of the use of attachment is anchorage purpose. So the movement intrusion can be achieved with Invisalign alone, or we can add horizontal rectangular attachment that is beveled incisally to achieve intrusion, or you can use auxiliaries as well. Extrusion is actually the difficult movement that can be achieved with Invisalign alone or clear aligner alone. There should be about 1 millimeter, 2 millimeter space at the gingival level if you want to use auxiliaries. Otherwise, you can use the gingivally beveled attachments if we are not planning for extrusion more than 1 millimeter. Lower extraction spaces, we have to add the vertical attachments that will help in tipping of the roots, especially if we move the roots. If we move the crowns, the root should also come into the extraction spaces. If the root is not coming into extraction spaces, the tendency of relapse is very high as well, and the result will not be good. What are the auxiliaries? Look here, this is handmade auxiliaries. You can make it with your own hands on the tooth itself in combination with the aligner, by making it the power arm. This power arm will make the force application near the center of resistance so that the root tipping can be avoided with this kind of attachment. Here it can be from the manufacturer power arm itself as well. So others is class 2 correction. Class 2 correction can be achieved with the distalization of molar itself, which can be about 3 millimeter, or we can add the class 2 elastics. Class 2 elastics and distalization, especially class 2 correction, we need distalization when we are reducing the severe overjet in case of class 2 correction, provided that the class 2 is not skeletal in origin. It can be achieved with the hooks, that is called a precision cut, designed with aligner technology itself, or you can manually include it with a nail clipper or with any cutting blades, or you can add manually any hook to it, so you can use elastics immediately. Midline discrepancies can be corrected with asymmetrical class 2 and class 3 elastics attached to the tooth on clear button. can correct for you a midline discrepancy. What are the limitations? One limitation is compliance. Because aligners are removable, the orthodontist must rely on the patient's motivation. If the patient is not wearing the aligner properly, it will be a great disadvantage. Removability of the aligners is advantage to the patient, but it may not be advantage to the doctor itself. If the patient is not using it properly, it will you cannot achieve your treatment objectives. All permanent tools should be fully erected for the treatment with aligners. It does not exclude the using of aligners in teenager, but it's good if the permanent tools are erupted fully when you choose a case. There is currently no capability of incorporating basal orthodontic change with a appealing system, thus restricting malocclusion to purely dental. Lack of operator control. Unlike fixed orthodontic treatment, in fixed orthodontic treatment, you can switch your plan to any direction. But once the aligners is fabricated, you cannot change your treatment plan. Otherwise, either you re-scan the patient and send it back to the aligners and manufacture another again, or you have to stop the aligner and plan the treatment differently. So it will increase the cost for you. So that is difficult for the patient and for the doctor as well if you don't properly plan from the very beginning. Inability of integrating hard and soft tissues of head into the computer system. There is what we call VTO, visual treatment objective. Visual treatment objective is not incorporated in the software. So you cannot integrate hard and soft tissue with dental changes in case of treating the patient with clear aligners. Others limitation is cost. It's about 3,000 to 9,000. This is a data from, it may not be similar for our cases, but cost is one of the disadvantage or limitation. Others are the less predictable treatment. Severe rotation, especially premolars and canines, should be addressed with auxiliaries other than Invisalign itself. How we are going to do the attachment? Attachment can be done with, first you have to explain what you are going to do to the patient in any procedure, in any dental procedure. First, we have to explain what we are going to do to the patient. Then cleaning of the plaque. I will show you a very short video after this. Cleaning the tooth of any plaque. There should need no plaque on the tooth because this aligner and this attachment should be very stable. It can be removed throughout the treatment. You can reattach it again, but it's good if it is fixed properly. First, you have to clean all the plaque, apply the etchant as any composite filling. Once you apply the etchant, you have to wait for about 10 seconds, rinse the attachment, rinse the etchant off, then dry it with the air, apply the bonding agent, little bit gently dry with the air, then light cure it, and load the attachment template with the composite and cure it. You can see this short video. Hi everyone, welcome to Yes, this is the end of the session. Please forward your question.
All right. Okay, thank you so much, Doc. That was such an excellent and informative session. So let's hear from our attendants if we have any questions. You can chat it on the Q&A box. So yeah.
One by one, let us respond.
Okay, Doc. So until the questions come regarding your certificates, as a reminder, just like usual, a post test will be posted on EDPA Telegram channel. So when the webinar ends, you can get the certificates when completing the test. So that's just a reminder. Any questions, guys? All right, so until your questions are forwarded, I'm just going to revise the points that Dr. Dida has presented. So we have discussed that aligners are custom-made orthodontic appliances that progressively correct malalignments. There are different technologies that are now being used, but Doctor has mentioned that commonly in our city, we have been using the liners. Clear liners are also FDA approved. And how this clear liners work is through continuous and small forces. We have also been discussing the steps of these aligners. So the first one is case selection. The second one, high quality impressions. Usually PVS is mainly used, but we have to be cautious to make sure that details are being recorded. And then we have approval of treatment steps on the web, and then construction of aligners and delivery to treatments. Then issues of aligners and reviewing, and the last step is finishing and retention. So there are different possible tooth movements. The first one is space closure, distalization, flaring, dental expansion is possible. Some cases are classified as difficult. This include multiple missing cases, severely tipped tooth, rotations more than 45 degrees as well. We have also discussed the biomechanics of clear aligners, where there are active components, that is deformation of the plastic aligner. And we have also discussed that there is retention, and undercut of the tooth is used for retention. We have to make sure that aligner deformation cannot be so great to overcome retention forces. So that's definitely a point that we must not miss. So other point that was mentioned is about attachments, which are small pieces of light cured composite resins bonded temporarily onto surfaces. And we have also discussed attachment categories as those that assist movements, auxiliary functions, and those that are augmentary. So attachments can also be passive and active. And we have discussed how horizontal attachments are for extrusion, vertical attachments for translation, single ellipsoids for crown rotation, and paired ellipsoids for root torque. So yeah, we have discussed those points. And regarding limitation, we have discussed about how cost is quite a limitation here, patient motivations, as they are worn by patients, and all permanent tools should be erupted. Not quite necessarily, but it's one of the limitations, and no capabilities to incorporate basal orthopedics. So it's only limited to dental malalignments, and the lack of operative control, as well as the inability to integrate hard and soft tissues, has been discussed. So definitely quite an excellent points that have been raised. That was just my summary. So I think we have some questions. Should I forward them to you, Doc?
Yes, yes.
All right. So the first question is by Nasir Kamal. He asked the difference between fixed appliance and aligners.
All right. The main difference between fixed appearance and aligners is that first, the fixed appearance actually it is fixed, it cannot be removed from the patient. The patient have no control over fixed appearances, but the patient have control over the removable appearances. In case of the Invisalign. Invisalign, the patient can remove and use it back, and with fixed appearance, the patient cannot remove it. So the operation depends on the doctor itself. One of their major difference is that their advantage. There's an advantage and disadvantage as well. The advantage of the fixed appearance over the clear aligner therapy is that the movement of the tooth, especially difficult movement, can be achieved with fixed orthodontic therapy, like severe rotation and movement more of the spaces more than 6 millimeter that can be achieved with fixed orthodontic treatment, especially root paralleling technique, is better on fixed orthodontic therapy than clear aligners. But for the clear aligners, the advantage is that the patient have control over the aligners. They can remove on this socially sensitive areas as well. The patient can keep their hygiene perfectly. They can remove the clear aligners and brush their tooth. There is no limitation in choice of food in case of clear aligner. The patient can remove and eat any food, but in case of fixed orthodontic treatment, the patient have limitation on choosing of food. For example, the patient cannot use acidic food regularly when using fixed orthodontic appearance, because there is high risk of caries, especially on fixed orthodontic treatment. The patient cannot chew on hard food when wearing the fixed orthodontic therapy. All this limitation is not included on clear aligners. The advantage is that clear aligner therapy is good for the periodontal health, because the oral hygiene is good in clear aligner therapy. They can clearly access everywhere. They can floss it, no restriction. So the periodontal health is good. But the data show us in the research, if the patient can excellently keep their oral hygiene with fixed appearance and with removable appearance, it is relatively the same for the periodontal health. But the majority of researchers have proved that periodontal health is improved with clear aligner therapy than fixed orthodontic therapy. Other thing is aesthetics. Aesthetics, fixed orthodontic therapy is poor in aesthetics, metallic look, and that is why majority of adult patients is reluctant toward using fixed orthodontic therapy and choosing uh, a more aesthetic one like clear aligner therapy. Other is the treatment duration. Treatment duration is relatively the same according to some researchers, but there is many researchers that approve that simple cases are faster with aligners than fixed orthodontic therapy, which will take about 3 to 6 months. But in fixed orthodontic therapy, in case of extraction cases and other complex cases, orthodontic therapy with fixed braces are more superior than Invisalign in these cases. But in combination therapy, combining fixed orthodontic therapy with clear aligners, that means using fixed orthodontics initially for severely rotated tooth and then clear aligner may make the treatment possible. So their major difference is treatment time, aesthetics as well, and choice of food, limitations of food. And these are, I hope it answers the question.
All right. So moving on to the next question, another attendee would like to know your experiences of Invisalign for extraction cases.
Our experience was extraction cases. The extraction case can be closed with Invisalign, but we support with elastics for the anchorage control. We support with elastics as well as we support with the hooks as well. If we are not using the hooks or we are not using the elastics, inter-archer elastics for closing the spaces, especially the extraction of the bicuspids, there will be the tipping movement. Actually, it will counter-generate the moment in cases of uh, extraction space closure. It will take much longer time than even fixed orthodontic appliances if you are not using any auxiliaries. But it will close the space, especially anterior tooth extraction is easier to close with clear aligner than bicuspid. It's still possible to close the bicuspid or premolar extraction by using elastics as well.
Okay. So another attendee would like to know if there is any differences between cleaner aligner providers and if there are any limitations among the providers.
Actually, there are a lot of clear aligner companies. The difference, some of them directly provide the cleaner to the consumer itself without involving the doctor. Some of them will virtually following the patients and uh, others will involve the doctors. The Invisalign companies will give us the ideas. They will open the ideas for you. You can clean check from their specific site. But their major difference is they clear align between clear aligners. Some properties are unique to some and others are not unique. For example, the smart track materials are unique to Invisalign. That makes the Invisalign more flexible. And the aligner company like Clear Correct are almost invisible. The thickness of the aligner in Clear Correct is more thinner than Invisalign. But the other use the combination therapy. The major difference is some of them are not using the IDS Invisalign doctor side that you can directly check from your account. Others you send it the clean check over the email other than IDS. Uh, much of them are simply commercial advertising than major difference. Smart Fort feature is unique to Invisalign.
Okay, thank you so much. So another attendee would like to know who will decide for the need of attachments, the doctor treating the patient or the company?
Good. You can request the attachment by yourself. Actually, the Invisalign ideas, the software, they will automatically prescribe the attachment depending on your prescription on the specific tools or specific tools. They will give the attachments, but when you are not satisfied with those attachments, either you can request the attachment on the specific tool or you can 3D edit on your Invisalign doctor site. For example, uh, many times the aligner technology, they may not include the and intrusion augmenting attachment other than the anchorage attachment and the rotation attachment and root paralleling attachment. They may not add the augmentation attachment for intrusion and extrusion. In that case, if you need or if you suspect the rotation of the tooth may not be clinically express itself or intrusion or extrusion cannot be achieved with the attachment provided with aligner technology, you can edit in the 3D software or test in kind of aligner that will send over email. You can request that I need this kind of attachment on this specific tools. But in case of Invisalign, you can edit within your ideas. It has 3D editing tools. You can attach on the specific tools. If you need for intrusion, bevel it incisally. If you need extrusion, bevel it gingivally. So either doctor request or there is a default attachment by aligner technology itself.
Okay, I think that answers the question. So another question is, can we do aligners for open bite? And if so, how can we correct it?
Very nice. Aligners, we can use it for open bite as well. But before using it aligner alone for open bite, we have to decide the severity of open bite. If open bite is not more than 4 millimeter, the aligner itself can achieve for you without even using auxiliaries. Intrusion can be achieved about 1 millimeter on the posterior side. Anyway, when we correct open bite, we have to make sure that there will not be the smile of the patient. We have to diagnose the patient first. The gingival display of the patient should be good. If we intrude or extrude, you have to rule out that. Then, when you come to the mechanics, intrusion can be achieved posteriorly on the posterior tooth 1 millimeter by aligner itself. If we intrude on the upper 1 millimeter and lower 1 millimeter, we intruded 2 millimeter. Even the aligner thickness itself will intrude the posteriors, the thickness itself. So if 2 millimeter is intruded on the posterior side, as you know, it is a twice. For every millimeter intrusion, we will close the bite 2 millimeter in the front. So if the 2 millimeter is intruded, we can definitely close 4 millimeter open bite in anterior side. But we will not stop on that. When we correct the open bite, as you know, even with fixed orthodontic therapy, there should be overcorrection. There should be a room for relapse. If we intrude 2 millimeter from the posterior, your 4 millimeter open bite is closed on the anterior side. But where is overcorrection here? You have to extrude the anterior tooth in front, provided that it will not cause the excessive gingival display. We have to extrude the anterior as well, intrude the posterior, intrusion of the posterior close for you open bite, extrusion of the anterior will make room for overcorrection. In this way, we can achieve open bite correction. What if the open bite is more than 4 millimeters? Severe open bite. Open bite can be class 1, class 2, or class 3, whatever. You can use TAD, temporary anchorage devices, on the gingiva. Then you apply the elastics and intrude or the posterior tooths while you are using Invisalign. So intrusion can be achieved on this way. Yes,
Okay, thank you. Thank you, Doc. Another question is the minimum age consideration for clear aligners and when aligners are recommended.
actually, it's good if it is good if there is no minimum age consideration. Actually, there is a Invisalign first, what we call Invisalign first. It cannot rule out in the pediatric mixed dentition period. Even in mixed dentition period, we can use a dental expansion to get a room for the coming or erupting tooth, aligning malocclusion, or in even case of the anterior tooth crowding, if there is discrepancy between tooth material and arch, we can expand dentally because the aligner company, the aligners can expand up to 6 millimeters of the dental expansion. But in case of case selection, it is good if the permanent tooths are fully erupted. Otherwise, the aligner cannot grip on and on under erupted tooth or short clinically crown tooth. Even an erupted tooth, what problem will it cause is that once you start the using of aligners, the tooth will fully erupt and the aligner cannot fit inside. So the permanent tooth should fully erupt, and then the full eruption of the permanent tooth is around 14 years like that, but it cannot rule out the Invisalign first for the teen during the mixed dentition period.
Okay.
Yes?
Okay, Doc. So Dr. Dagmar Gusai, thank you, Doctor, for your informative explanation. His question is, shall we bond the clear aligners in every session like the one that was showed in the video?
Every session means?
I think he's trying to refer for every appointment.
No. No, we will not actually repeat this. It will reduce the chair side time, by the way. If the aligner is, attachment is not detached, we will not do anything. Sometimes the attachment, the temporary attachment of the tooth may detach. So we specifically detach that attachment. The only thing is that the template that we used initially for the using the attachment may not fit on the 10th aligner or 18 aligner. What we are going to do, we have to cut the attachment template specifically for that broken attachment and then reattach it. We will not repeat all that procedures.
Okay, thank you. Dr. Idus said thank you for your great presentation, and he would like to know how we can correct the canine impaction using aligners.
That is the limitation of the aligners alone. You cannot use aligner alone for the impacted tooth. What you can use auxiliaries. How we are going to use auxiliaries that after exposure, provided that the position of the canine is good after exposure, uh, you can use the elastics that is attached to the hooks on the aligner itself. Elastics from the impacted tooth to the hooks on the aligner. You can wrap it around, but that is one of the limitation of aligner alone. Aligner cannot bring the impacted tooth into the arch, especially if it is not accessible with the patient.
Okay. So another attendee would like to know who will be the candidates to wear Invisalign.
Candidate actually, as I think she missed the presentation or whatever,
Yes. Yeah.
maybe the candidate, actually the adults are a very good candidate because they can accept all the instructions. uh, there will not be limitation for they will understand you, they will be compliant, they can understand what we explain for them. The adult patients are perfect for the Invisalign, but nowadays the teenagers are also aware of the technologies, how can technology can enhance their treatment. So the internal motivation of the teenagers may make them also a candidate for the Invisalign cases.
Okay, thank you. Dr. Tamam would like to know further information that you may have on follow-up of this patient on clear aligners and in details maybe. And also,
Follow up.
sorry, Doc,
Yeah,
what to check during those appointments?
what we are going to do during the appointments.
Yes, the
All right.
follow-up, what the follow-up
That,
is like
that
and what to check
good.
during appointments.
I got his question.
Okay.
What we are going to do is that we have a clean check. The clean check on your IDS Invisalign doctor site. So the clean check will show you at each stage to what extent the tools move. For example, you can see the virtually on the aligner 10 or aligner 4, the the position of the tooth occlusally, backally, you can see it on the your clear on your IDS. You check the patient and you check your virtual correction or clean check. If the clean check your clean check and what you see clinically on the patient is not the same, it means that your aligner is not tracking. The very good indication is that if the movement is not achieved, the aligner itself will not fit to the patient. There will be a tracking issue. It is called a tracking issue. The patient cannot put his aligner on. It cannot go. So if the aligner is not tracking, or if you see the excess aligner in the patient's mouth. When the patient try to put the aligner, let me make it clear, try to put the aligner on, the aligner is not moving in. It means that there is a tracking issue. It means that the tooth is not moving in us to the prescribed point. So at that time, maybe if the patient lost the one aligner or go to the next, that is actually on the follow-up. Uh, you check your clean check and you check what is in the patient mouth. So if it is not compatible, that means your aligner is not tracking. If the good indication, the tracking issue, the patient cannot even put his aligner on. So it will make you for you easier. On the monitoring, there is also the monitoring software on the IDS itself. You can check it on that as well.
Okay, thank you. So another question by Roha Ermias is if you know the best company that fabricate aligners, perfection and cost. I think this question has been asked. It has something to do with smart trackers, I think. Yes, Doc?
Yes, yeah.
So I think that answers your question, Roha. The next question is by Burhanu Taddesa. Thank you for the simple and clear presentation. His question is the role of general dentist and clear aligners. Can you explain clearly about attachments? What about refinement, staging, tracking, and engagers?
All right. Actually, in general dentist, you can get training with the clear aligners. Maybe the difference is that how you diagnose and plan your treatment. If you diagnose and plan your treatment correctly, it will not limit you doing the clear aligners as a general dentist. Attachment is usually, it is a default that will be provided with the aligner company depending on the treatment plan. Your treatment plan will clearly mention on the prescription text, I need this one, I need to achieve mesiodistal correction of the tooth, I need to achieve class 1, I need to achieve my midline, or I need to reduce overjet or overbite. Once you prescribe everything for the on the prescription for the clear aligner technology, there will be the default attachment that will put on the clean check itself. But if you are not satisfied with the attachment is actually the composite, a temporary composite that will be attached on the tooth. If you are not satisfied with that, or if you need some augmentation, you need some overcorrection, you might ask for additional attachment, or you can edit by yourself on the 3D tools, so you can achieve some intrusion or extrusion movement or anchorage movement. Maybe I think some of his question is about attachment. Can you please repeat his question?
Okay, so his
Attachment
question
role.
was, yes, he asked about attachment role and also about refinement, staging, tracking, and engagers.
All right, good. Yes. Refinement is that once the patient finish a line, you may find that the malocclusion is not corrected as you wish. The patient may complain as well. The patient may complain, this is not corrected, that is not correct, or you can see on your clean check, what is there on the clean check is not clinically expressed in the patient mouth. You can ask for the refinement. Refinement differs from the package to package. There may be a limited refinement, or the refinement up to 5 years, or refinement up to 3 years, or refinement twice, or so. It depends on the package. Package can be light, moderate, or comprehensive, as we currently doing. So the refinement numbers differ. Refinement is specifically if you are not achieving what you need, you refine it again. Refinement usually is cost-free. The aligner technology will not ask you money for doing the refinement. Maybe they will ask you for completely changing the plan and getting another aligners. The tracking issue is that when the patient is using the aligner, sometimes they lost the aligner. Or when they lost the aligner, when the patient try to insert the next aligner on their mouth, or they miss the time that they wear, there should be the recommended time for wearing a liner, which is about 22 hours per day. If they are not properly wearing it, there may be a tracking issue. If there is a tracking issue, there is a clear. It's good if I show you. Maybe I didn't bring the picture because we our fundamental issues only on the fundamentals. You see, the aligner will not track, means that it is not fitting in the patient tooth. If it is not fully fitting, you will see there is excess over the tooth, and the patient may not bite if it is on posterior properly. If there is a tracking issue, you will sometimes instruct the patient to bite on the rubber. There is a rubber that can be provided with aligners, or you can use any rubbers, and then the patient chew on that rubber, and it can be fitted back properly. If the fitting issue continued and it is not properly being moved back, either you clinically check moving back to the another aligner, previous aligner, and make sure that it is fitting correctly, and you have to find the reason for that. I think it answers his question.
Yes, I think that sums up his question. So another question is, can a patient with epilepsy taking anticonvulsants be on clear aligners?
Actually, in case of using, in that kind of cases, the one thing is compliance issue. The patient with the epilepsy, once the accident happened, you see, in the aligner, chewing on the aligner is not allowed. When you are chewing, when you are using the aligner, you have to remove while chewing or something. Why that is needed? That excessive force on the aligner will affect its properties, the properties of the aligner. When the properties of the aligners is affected, the movement will not be effective. The elasticity of the aligners will be affected, the property itself, that is elasticity. The deformation capability that will apply active forces will be compromised. So the patient with the epilepsy are not recommended due to the severe grinding of the tooth on the aligners. The properties will be affected so much so that it may not work for them.
Okay, thank you. So Dr. Qudus would like to know how long it takes to complete such cases like spacing, crowding, or so. I think he's trying to ask you how long the average time is for completing a clear aligner case.
Very good. It differ from company to company. Some companies say 6 to 18 months. Clear aligner technology in case of Invisalign is set 8 or 6 to 24 months, depending on the case. Some even literature say that 3 to 6 months for a very simple cases, and more than even a year for extraction cases, even 2 years and above for some extraction cases. For simpler cases, the clear aligners are superior than fixed orthodontic treatment, and for complex cases that need orthodontic treatment, fixed orthodontics appearance are superior. So he can take as an average 6 to 18 months among the aligners. That is more common. But in case of Invisalign, it extends up to 24 months. The complex cases usually taking more than that is not recommended for the clear aligners to be treatment method.
Okay. So another question is, can we change a started fixed orthodontic appliance treatment to Invisalign aligner?
Started one.
Yes, a started fixed orthodontic appliance
Yes.
treatment. Yes.
Yes, we can switch, but when we switch the fixed orthodontic treatment, the patient will on fixed orthodontic treatment. When you remove the fixed orthodontic appearance, immediately apply the retainer, invisible retainers, immediately. If you don't immediately put it on the retention, when you scan the patient or take the impression, there will be a relapse to the previous original malocclusion. When the aligner come back, the aligner may not fit for you, but you can switch provided that you are using retainer immediately.
Okay. So another question is by Dr. Andres. He actually asked 3 questions, so I'm going to forward them one by one. The first one is, are the resin attachments custom made with the Invisaligner? Are they offered with a aligner from the company?
No. You can use resins, either flowable composite. Some prefer flowable composite. Some prefer ortho composite. But it's good if it is flowable. But if it is not flowable, you have to push the composite well to adapt it to the attached template wall. Otherwise, it's not from the aligner company. You can use flowable composite or you can use orthodontic composite itself.
Okay, so his second question is how we can replace if the patient has broken or lost one of the aligners from a series.
All right. We will not replace it. What we do is that if the patient lost one aligner, we tell the patient to wear the next aligner for the for example, usually we use the aligner for 7 to 14 days. If the patient lost one aligner, for example, let's say aligner 5 is lost. The patient is on 4 aligner, 5 is lost. We will tell the patient to use a six aligner for 28 days. If we are using 14 days as a basic follow-up days, we will tell the patient to use it for 28 days with 6 aligner. If the patient, if it is not fitting, maybe you re-scan. Most probably the next aligner will fit, but you have to make double treatment period, like 28 days.
Okay. So a last question from Dr. Indris will be, some company agents in Ethiopia say they will do all the steps starting from the treatment plan. So he asked if we can trust them.
Nope. It is on your shoulder, by the way. How can you trust someone? The patient can come to you. The patient chief complaint. The patient say, we need this one, we need this, I need this one. Taking the patient chief complaint, then you specifically plan the treatment for your patient, and then you execute the treatment plan according to what you need. As you say, even in the any technology, if you put some garbage in, there will be garbage out. Who you are going to blame if the treatment is not achieved? I don't recommend such kind of treatment, actually.
Okay, thank you, Doc. So another question is by Dr. Efa Alamu. Can we use aligners with a missed tooth?
Multiple missed tooth is one of the contraindication of the aligners, because aligner cannot grip. If there is no tooth, multiple tooth missed, the aligner needs another tooth as an anchorage for the movement of the others. But missed tooth, sometimes we have missed premolars, and 6 and 7 and 8 is there. The anterior tooth is crowded. Let's say 6 is missed, and one of the premolars is missed. But if you have some posterior tooths for aligner to grip on, and you have a plan of aligning the anterior tooth, in that case, okay. But multiple missed tooth is one of the contraindication of the aligner.
Okay, thank you, Doc. So another question is by Dr. Helena. You have mentioned all permanent teeth should fully erupt for clear aligner treatment. What is your experience with Invisalign First, which is designed for 6 to 10 years? I think she's trying to ask you if you have used clear aligners or Invisalign for mixed dentition and what that experience was like.
Yes, yes. I use the Invisalign first for the teenagers, but the issue that we face is that you will achieve easily uh, the alignment of the tooth, especially the anterior tooth. During mixed dentition period, actually you have to have at least six. It means you have to have, I think she understands six. 1, 6, 2, 6, 4, 6, and 3, 6 is posterior, the first permanent tooth to appear in the mouth. And then the anteriors should be there. They will be aligned on the anterior, and expansion can be also achieved. The issue that we face actually when we use Invisalign first is that once the molars, primary molars start to exfoliate and then the premolars come, there will be the fitting issue. The, the aligner will fit properly on the six and the anteriors. And the issue is that when the premolar erupt, actually the eruption will be impeded of the premolars. They tilt lingually sometimes. In that case, is what you have to do is that you have to remove the lingual side of the aligners to make the path for the eruption. At least lingual, you have to reduce manually. No problem. You can reduce it, and then you will allow the premolars to arrive into that space. But the good candidate is adult. You can also use Invisalign first for correction of minor malocclusion, especially if we need some expansion for making the room for whose material to arch length discrepancy.
Okay, thank you, Doc. Another question is how many times can patients remove aligners daily?
Actually, the recommended times for the patient to wear aligners is about 22 hours a day. If the patient is wearing less than, he can remove many times the aligner, but to make sure to explain to the patient is that if he within 24 hours, if he is not using the aligner for 22 hours, he have to add that hour. He have to compensate that hour on the next day before going to the next aligner. That it is that simple. Once the one aligner reach 22 hours, it should he cannot move to the next aligner.
Okay, thank you, Doc. So the next question is by Dr. Yosana. Once we deliver a liner to patients, at what interval we appoint patients for checkup and for what reason, I think?
All right. Sometimes the procedure that we call IPR, interproximal reduction. Interproximal reduction, it may be done on the first visit or it may be done on different anterior. We may have the IPR on different tooths. If we don't have IPR, interproximal reduction of the tooth for relieving of the crowding, we may not appoint the patient is frequently. For example, we can allow the patient to go for about 3 to 4 months, is no issue. The only issue is that you have to inform the patient that if the attachments are removed, that attachment may be necessary for anchorage or specific tooth movement. The patient should come back to get that attachment fixed. But if the attachment is not broken and the patient has no IPR in between, you can give about 10 aligner even to the patient, no issue. But if there is a tracking issue, if the patient cannot move, put his aligner in, you have to inform the patient to come to the doctor for a revisit. Otherwise, the frequency of revisit of the aligner depend on if you have IPR procedure or you don't have IPR procedure, or you want to follow the movement for some specific reason, for severely rotated tooth or whatever. Otherwise, you don't have specific intervals to call the patient back.
Okay, thank you, Doc. Another question is by Dr. Qaddus. Is there a retention phase here? If so, how?
The retention phase, actually, in case of retention of the, in case of clear aligners, once you finish, actually there is a finishing procedure for the aligner. Finishing is necessary for aligner as it is necessary for fixed orthodontic therapy. Once the patient finish aligner, the usual thing that happens is that the posterior tooth of the patient is disoccluded. At that time, you have to cut the posterior part of the Invisalign and let the tooth settle by itself for even about 1 month to 2 months. Sometimes 3 weeks or 4 weeks is enough. Once it is settled, some of the practitioner will let the last aligner stay there, but it is not the good means of retaining it. Either we order the Vivera retainers, uh, or Vivera retainers is a Invisalign company specific retainer that you can order for your patient, or you can use the local vacuum formed retainers. But for the retention, actually retention, as for any orthodontic uh, treated cases, the retention depends on a specific case. If the case need fixed retainer, you have to do fixed retainer for your Invisalign patient. If the retention need, especially for those deep bite, if you need some kind of the deep bite overcorrection and retention mechanics, attachment on the sides of the lingual surface of the upper should stay there. And the retention depends on the cases. For fixing for space tools, you have different retention. For skeletal class 3 percentage, for example, in case of fixed orthopedic therapy, you have some retention mechanics, but in case of Invisalign, you cannot use it for skeletal cases. For deep bite also, you have another retention protocol. Retention protocol is not aligner specific, but it is case specific, as in case of fixed orthodontic therapy.
Okay, thank you, Doc. Another attendee would like to ask you that, can you please recommend us where we can get more trainings online and offline regarding aligners, and also the most common company used globally?
Actually, the most common company in popular company is currently Invisalign, and the second one is Clear Correct. The Invisalign company actually it is based in Kenya also, with the LICAS industry. You can find in Dubai as well. You can find in India. I think for Ethiopia, the feasible one is either Kenya, Ghana, or Dubai. You can get it from there online. Their industries are advertising themselves as well.
Okay. So the next question is, I think we are having a lot of questions. So the next question is about the basic differences between fixed orthodontics and Invisalign aligners in terms of mechanisms of tooth movement or biomechanics.
In terms of I think I answered that question. In terms of biomechanics, actually, the fixed orthodontic therapy, we use brackets. Those brackets have the point of contact that will control or generate the moment for the controlling of tooth movement. Body movement, tipping, torque are more easier with a fixed orthodontic therapy than clear aligners. Actually, in clear aligners, in case of clear aligners also, we can use the auxiliaries as a power arm. That power arm either can be done manually, or it can be fabricated with manufacturers. And then we can use that, especially the mechanical difference is on space closure. On alignment techniques, it does not matters like much in case of biomechanics. Intrusion, extrusion are far better in fixed orthodontic therapy alone, if you are using the clear aligner alone. But in space closure, the anterior extraction space closure is easier with Invisalign than bicuspid space closure. Space closure in extraction cases with Invisalign need auxiliaries. Auxiliary either had to make it possible as much as possible to the point of resistance. In point of resistance, to achieve that in case of with Invisalign, it is difficult if we are not using the auxiliaries. But in case of fixed orthodontic therapy, as you know, we have 2 points of contact for moment generation. We have a different type of the bracket size that will generate for us a moment, especially a rectangular fixed orthodontic brackets can generate enough moment to prevent the tipping. The tipping is usually root paralleling is difficult with clear aligner therapy, but minor space closure, if we use a hook, no problem. If we use a power arm, we will come closer, more closer to the center of resistance, so that the root tipping will be avoided, but generation of the moment can be also possible with the lingual pressure from the aligner itself.
Okay, thank you. The one of the questions is there a difference in anchorage used in depending on the cases?
Yes, there is a difference in anchorage usage. If there is a mesiodistal movement, especially in extraction space closure, we have to use anchorage. This anchorage can be achieved by putting the attachment, especially the vertical rectangular attachment on the posterior tooth will give us anchorage, and also optimized attachment on the posterior as well as on the anterior if we need some slight medialization. But can you repeat the question, please?
Yes, Doc, no problem. So the question is there a difference in anchorage used depending on the cases?
Yes, yes, yes. In case of extraction cases, we need more anchorage, but in case of non-extraction cases and space closure, we may not need that much anchorage. The aligner grip itself, the aligner undercut of the tooth itself may give you enough anchorage for minor correction of rotation and space closure. But in case of extraction cases, as we all know, it is must to maximize our anchorage on the posterior side. Either that anchorage can be enhanced with auxiliaries like elastics on anterior or posterior tooth movement. Elastics plus vertical attachment on the posterior tooth can add anchorage to the aligner.
Okay, thank you so much, Doc. So I think Nasir Kamil said after aligner treatment, can we use retainers like fixed appliance? I think you just answered that question. Doctor has said that retention is case-based and not retainers, and not, retention is case-based, and depending on the case, we can use fixed retainers or vacuum retainers. Is that correct, Doc?
Yes, yes.
Okay, I think that was the last question. Everyone is thanking you for your seminar. I don't think we have further questions. Okay. Yes, I think that was the last question. Thank you so much, everyone, for raising interesting questions. It definitely made the session quite an interesting one. And thank you so much, Doctor, for such an insightful session. And thank you for answering all of the questions that was forwarded.